So hello and welcome everybody to this webcast, which is about Mitazalimab, a CD40 directed monoclonal antibody being developed on behalf of Alligator Bioscience as a potential treatment for patients with pancreatic ductal adenocarcinoma. My name is Sumeet Ambarkhane. I'm a physician scientist in clinical and oncology drug development and chief medical officer at Alligator. Today, we have the pleasure and the privilege to have with us Professor Jean-Luc Van Laethem, who is an expert clinical oncologist as well as the head of the gastrointestinal oncology division at the University Hospital in Erasmus in Brussels. Professor Van Laethem is also the principal coordinating investigator for the ongoing Optimize 1 clinical study of mitazalimab in pancreatic cancer. So welcome, Professor Van Laethem.
Hi, Sumeet. Hello.
So just to get started, if we go to the next slide, uh, maybe we should start the discussion with Professor Van Laethem giving a brief perspective on what is the current standard of care for patients with metastatic pancreatic ductal adenocarcinoma. What are the outcomes with those standard of care therapies, the unmet needs, and how does he see the role of emerging and new investigational therapies? Professor Van Laethem, could you please comment on that?
Yeah, sure. I think it's important to delineate the therapeutic landscape of metastatic pancreatic ductal adenocarcinoma. And so by today we have different standard of care. One is FOLFIRINOX, derived from the phase 3 French study published some years ago and demonstrating a huge benefit as compared to gemcitabine alone. And the other standard of care, it's gemcitabine combined with nab-paclitaxel. This was also derived from a phase 3 study comparing the combination against gemcitabine alone. And so usually we consider to use FOLFIRINOX in fit patients without any comorbidities, and the patient older than 70 years. And for the gem-nab-paclitaxel, usually we can use that in patient with PS0, 1, maybe 2, but it's probably better tolerated than FOLFIRINOX. And for patient with frailty or aging patient, probably we have to use gemcitabine alone. Of course, we will have now a new emerging therapy which is needed to improve the outcome of this patient, because the overall survival of this patient is around 1 year, considering this therapy. So we have to do better, and so we have two different options. One is to use targeted therapy based on molecular profile of this tumor, but which is more complicated because there is a lot of mutation. And one of these is now the BRCA mutation we can now target, but in selected population. And the other emerging therapy is the therapy using immunotherapy, but we have to know that up to now this setting is very complicated, and so we have to go for new investigation.
Mm-hmm. Thanks a lot. I think that sets a very good sort of background and perspective, such that we can go deeper into what mitazalimab is and how are we conducting its clinical development in patients with pancreatic cancer. So next slide. Right. So mitazalimab is a CD40 agonistic monoclonal antibody, um, which targets something called as a tumor microenvironment, which has been under research and development for for a while now, and its role in the importance of as a therapeutic target is getting more and more clear as the research is progressing. Um, Many of us would know that pancreatic cancer is considered as immunologically cold tumor. That means that it has a lot of fibroblastic tumor stroma and not a lot of influx of T cells, which are typically contributing to anti-tumor immunity. And therefore, the disease morphology itself prevents penetration of therapeutic approaches, including chemotherapy. Next slide. And in that context, mitazalimab can play a very important role, such that by binding to its target in the tumor microenvironment and other immune-related cells, which is CD40, it results into activation of dendritic cells as well as macrophages. Activation of dendritic cells results into increased antigen presentation and a better infiltration of T cells, whereas activation of macrophages converts the sort of tumor microenvironment from an immune suppressive type to a more immune active type, which can be better in terms of tumor cell killing. Next slide. So let us have a brief look at the study design and the overall planning for this clinical study, Optimize 1, which we are doing with mitazalimab. Next slide. Uh, this is the treatment scheme that mitazalimab as the antibody therapy is the first treatment that is administered to patients who successfully pass the screening procedures and eligibility criteria. 1 week after the administration of mitazalimab, the FOLFIRINOX chemotherapy it started, which typically goes over a period of 48 hours. And at the end of that 2-day duration of FOLFIRINOX chemotherapy, mitazalimab is administered again. So the first cycle of treatment is 3 weeks in duration, and thereafter the subsequent treatment cycles are of 2 weeks duration, which is consistent also with the frequency with which FOLFIRINOX chemotherapy is typically administered to this patient population. And every 2 months, the patient undergoes a CT scan to look at how the disease is responding to the treatment, and the treatment as such continues until disease progression or unacceptable toxicity. And even beyond treatment, the study continues to gather data on patients' overall survival. Next slide. So Optimize 1 started as a dose escalation approach, where a lower dose of mitazalimab, 450 micrograms per kilogram, was administered to the first 6 patients in the study in the combination with chemotherapy. Once that dose level was cleared by a data review committee consisting of clinicians and experts, the study proceeded to the next dose level of mitazalimab, 900 micrograms per kilo, and even that was considered as safe and acceptable in terms of tolerability and the overall feasibility of this combination, such that the remainder, basically the main expansion part of the trial, was initiated with this 900 micrograms per kilo of mitazalimab as the dose level to be administered in combination with FOLFIRINOX. Upon availability of the data from 23 evaluable patients, the study has had a pre-planned interim futility analysis to look at and make sure that the responses are basically fulfilling a certain prerequisite. And only then the study could continue. Otherwise, it would result into a stop of recruitment. Professor Van Laethem will discuss a bit more on that in a few seconds. And essentially, beyond the interim analysis, the study design allows it to continue. Uh, to complete its recruitment with a total of 65 patients. The primary endpoint of the study is response rate, measured by the RECIST 1.1 criteria, and the secondary endpoints are standard endpoints such as duration of response, progression-free, and overall survival, as well as safety, pharmacokinetics, and pharmacodynamics. Next slide. So with that, I would request Professor Van Laethem to take us through this interim analysis and the results of it. Professor Van Laethem.
Yes, Sumeet, I'm pleased to present the first data of this important study. Next slide. So this is the futility interim analysis overview, and this analysis was based on the data cutoff on December 8 on 2022. For this, we use the first 23 patients for the futility and efficacy analysis. All patients receiving Mitazalimab at a dose of 900 micrograms per kilo combined with the FOLFIRINOX for at least 2 cycles and at a response assessment until cycle 8. For the safety analysis, we count on 43 patients, all patients receiving at least 1 dose of Mitazalimab, either the dose of 450 or the dose of 900 micrograms per kilo. The next slide. So the primary endpoint was the evaluation of response rate, and for this we usually use the RECIST criteria, which is based on the measurement on the size of the different metastases, which are considered as the target, as it is shown in this different slide, and CT scan showing different metastases. And we consider the different response to therapy in the different ways. So complete response is defined by the disappearance of all lesions and no new lesion appeared. Partial response, it's a decrease of 30% from the baseline measurement and no progression of the other lesion. Stable disease is no progression and no new lesion. And progressive disease is based on an increase of 20% change from the baseline measurement. So with this in mind, the next slide, please. We can now define the primary endpoint of the study. And of course, it's important to remind the statistical assumption for the futility analysis. And it was assumed that if the modified FOLFIRINOX response rate was around 30%, we can assume by adding Mitazalimab, the response rate will increase to 45%. And so with a power of 80% and an alpha of 0.1, we can design the number of patients needed for this evaluation. The number of patients required is 23. As you can see, if a number of responders is equal or below to 7, the study will be stopped for futility, and it's not conclusive. And if the number of responders is above the number of 11 patients, the study will be considered for efficacy. Next slide, please. So here are the results, and you can see the overall response rate is 52%, and the disease control rate is 91%. And so, based on the statistical absorption, the study was considered to pass futility and continues to full enrollment. So this is an important key step and good news showing that the primary endpoint was met. Next slide. Overall response rate was a primary endpoint, but we have secondary endpoint, efficacy endpoint, but which are not still reached, which is PFS and overall survival, and also the duration of response, which is also an important criteria for evaluating the efficacy of combination therapy. The PFS and OS will be present later when we have more mature data. Next slide. Safety is also important. So if we look to the safety data, and if we combine mitazalimab at the doses of 900 micrograms per kilo to FOLFIRINOX, it appears that this combination is feasible and quite manageable. And the overall safety profile largely is consistent with the FOLFIRINOX chemotherapy. So there is no new safety signal and no evidence of additive toxicity. This is also an important point. And most importantly, there are no deaths due to related adverse event reported so far. Next slide.
Yeah, so maybe we can pause here a bit and try to understand and interpret these results. And particularly, I would be interested in knowing your thoughts on this, Professor Van Laethem, because these are results that look encouraging, reflecting the combination of mitazalimab together with modified FOLFIRINOX as a chemotherapy. Can you put these results into context with the reported data with FOLFIRINOX, and what do you think about the contribution of mitazalimab to this therapeutic regimen?
Yes, as you know, mature data with FOLFIRINOX provide a survival of around 12 months and a response rate around 30 to 33%. So clearly, these are preliminary results, but the response rate is it's over that, and it's higher. So I think that it's clearly a good signal. Especially when we consider also the disease control rate, and for the first patient, and we have the experience in our center, considering also the drug exposure, the combination exposure to our patient with what we look, it's a good persistent benefit if the patient are responding to this combination with a good quality of life and a good manageable safety profile, especially after some dose adaptation and after 1 or 2 months of exposure. And we have no patient who are treated more than 1 year in this with this combination. So this is clearly a good signal. Of course, it's preliminary, but the primary endpoint of the study was met, and so we can go with some ambition and hope to the next step of this development.
Mm-hmm. Thanks. I think that's very encouraging to hear from you as an expert, like clinician who's involved in the management of these patients on a day-to-day basis. The other thing that comes to my mind is the recent Napoli 3 trial and the results that were published from a regimen that is similar to FOLFIRINOX, just that it contains a liposomal formulation of irinotecan. So what do you think about the results from the NALIRIFOX regimen, and do you think mitazalimab should also be combined with this regimen that contains the liposomal irinotecan?
Yeah, this is an important study, also an important step, because this is a direct comparison between NALIRIFOX, FOLFIRINOX-based regimen and the gem-nab-paclitaxel combination. And clearly it was shown that the NALIRIFOX combination did better than the gem-nab-paclitaxel. So probably for fit patient, we can consider this NALIRIFOX combination as a standard option in this fit population. And subsequently, I think that Mitazalimab could be a very good partner to this kind of combination. And what we can maybe speculate is that the synergy between chemotherapy and immunotherapy, like it was proposed with the Mitazalimab pathway, I think it's a reinforcement of the effect of chemotherapy. And this could explain maybe that the patient are longer control with this combination compared with chemotherapy alone. Of course, it's only a speculation by today, but if we get additional results, maybe could be a good explanation and hypothesis to be fulfilled.
Mm-hmm. And what do you think about this combination in other segments of pancreatic cancer patient population? Do you think there's a possibility for the development and this treatment can be explored in those different patient segments?
I think that if the combination with chemotherapy and mitazalimab is proven to be efficacious in the metastatic setting, we can go for a less advanced setting, which are also important. Very good setting is the locally advanced disease, because maybe in this setting we can use less chemotherapy and more other emerging therapy like immunotherapy. And maybe in this setting, mitazalimab it's a good candidate. That's probably a good setting. We can also use this combination in the perioperative setting. Maybe it's a bit early to use it or to test it, but the neoadjuvant setting is very interesting because you can follow the target, you can follow the tumor, and you can also analyze the tumor and do analysis, explorative analysis, molecular analysis, etc., exploring the effects of this combination and especially the role of mitazalimab in the tumor environment and in the immunological components.
Indeed, and how about mitazalimab as a CD40 directed immunotherapy in tumor types other than pancreatic cancer, which may belong to either gastrointestinal or other tumor types? Do you think this treatment has a role or could have a role and should also be developed into any of the particular tumor types?
That's a good question. Probably the answer is yes. We know that in other GI cancer, immunotherapy using PD-L1 or PD-1 checkpoint inhibitor are emerging and are now standard of care in, for instance, esophageal tumor and hepatocarcinoma. So probably mitazalimab with these own properties and characteristics can offer something more than the third generation immunotherapy. So the biliary cancer, the hepatocellular cancer, and maybe also the colon cancer are good candidates to be tested, especially if we use the same combination, for instance, FOLFIRINOX with Mita.
Mm-hmm. Yeah, thanks. That is very helpful and encouraging.
I think that the next step is the primary endpoint is now met. Then we will confirm with further analysis this data in terms of response rate, but also in PFS and OS. And the next step is to design a phase 3 trial. Clearly, we need a randomized phase 3 comparing FOLFIRINOX or NALIRIFOX with the full combination with mitazalimab. If we want to put this combination as a new standard of care, we definitely need a randomized phase 3 study.
Yeah, absolutely. I mean, completely agree with your thinking and suggestion there. And indeed, as we saw from these preliminary results from the interim analysis, the response rate appears quite promising with the 52% of responders, and also we acknowledge at the same time that that data regarding time to event endpoints such as duration of response, particularly progression-free and overall survival, it will take a bit of time before it gets mature, and we are planning to do that in our subsequent analysis later in the year. As of now, these data from this interim analysis are going to be submitted to the upcoming scientific meetings early summer this year, and based on the successful crossing of the futility threshold, the patient enrollment for optimized one study, as well as the treatment and follow-up of those patients who are in treatment and in the study, is ongoing, and we are hoping that the primary analysis of the trial will be available to review early part of next year. So that looks to be on track. And again, as a next step, we are undertaking all possible efforts at Alligator to think through the subsequent development possibilities, what may be the requirements of the next steps in terms of development, and eventually get into discussions with key regulatory authorities such as FDA and EMA. So I would say stay tuned for the next steps in terms of development that we are undertaking from our side on Mitazalimab. So with that, I would say a big thank you, Professor Van Latham. It was great to have you today on this webcast, and thanks so much for sharing your expert opinion and perspective, and importantly, the data and the results of the interim analysis of Mitazalimab. And wish you a nice afternoon.
Thank you, Sumeet, and see you for the next and important step. I'm sure of that.